Hello, everyone. My name is Nadja Grobe, and I'm the head of the RRI Basic and Applied Laboratory Sciences. And I welcome everyone to today's talk. And I like to talk about the molecular insights driving precision AVF treatment and diagnosis. So here I want to quickly look into the history of 56 years of AVF. Actually, a arteriovenous fistula, or AVF, was first introduced in 1966. It's 56 years ago when doctors Brescia, Gimino, Apple, Hurwitz, and their colleagues introduced this new way of doing chronic hemodialysis. In fact, in an interview back in 2006 with Arena and Urology News, Dr. Chimino said, at that time, any place that did one dialysis session a week was considered a big center. Now, New York had 4 hemodialysis machines, and it was really a big deal if you had one and you were able to dialyze a patient. At this time, the access to the blood was kind of still investigated. And when Dr. Jimino went to the Congress of the American Society for Artificial Internal Organs and introduced his novel technology, he was very surprised that there was no comment. And a colleague later contacted him and said, if you have 100 patients, give me a call. At that time in the 60s, Dr. Jimino only had collected data on 12 patients. So this technique became very famous and we still use it nowadays. There are other techniques that do not require a surgery. And here I'm introducing 2 of the non-surgical procedures to create an AVF, which is the ellipsis procedure using thermal technologies and the wavelength procedure using radiofrequency technologies. Those are very promising new ways to introduce to have a vascular access that's very promising because it increases patient satisfaction just because there's no surgical scarring. It only requires local or regional anesthesia. There's no minimized arm disfigurement, and it's shown to be safe and effective and similar to the surgical procedure to create an AVF. It already received CE mark and is approved by the FDA. So what we currently do with the surgical AVF creation is going in, connecting the artery with a vein, and wait for the AVF to mature. What we don't really know is when the AVF is ready to be used, and this assessment is based on physical examination. And here on the left, I show the rule of sixes, which is just called the rule of sixes because of the number 6 being a characteristic of this rule. The rule is an interesting rule, but it seems that it has not been validated. In fact, the new Kotaiko guidelines, the updated guidelines, mention that the vein depth from the surface of the skin, less than 6 millimeter, needs to be updated to 2 millimeters, just because the outcomes when you go deeper are not beneficial for a successful AVF maturation. It seems a subjective criteria. It's more like a look, feel, and listen approach, and that questions a little bit how transferable this physical examination is to perhaps young nephrologists that wanna learn how to assess the AVF and its maturation status. On the right, you can tell that another tool is currently used. If you have access to an ultrasound, you can actually use the system to plan and evaluate the maturation process. Here is an article that not only shows that there are huge variations between countries for the time to first cannulation, but also in terms of successful use. So let's first look at the time to first cannulation. We are going from East Japan through Australia, New Zealand, and Europe, all the way west to the United States. And you can clearly see there is a trend in longer times to first cannulation going from Japan to the US. In Japan, the median time to first cannulation is 10 days, while in the US, it's almost 3 months median time to first cannulation. Unfortunately, this is um, correlated negatively with the successful use of an AVF. So while in Japan, it not only takes less time to first cannulation, the AVF can be used successfully for more than 30 days in 87% of the cases, while at the other end in the US, it takes as a medium time to first cannulation almost 3 months, but also the successful use over 30 days is less compared to Japan. So this doesn't look good. And the question really is here, what are the reasons for these huge international differences? And it's clear that we have not really understood the complex pathogenic factors that are involved in AVF maturation. We clearly need an objective, reliable, and validated screening procedure. And there is a meta-analysis done by Morton just recently where they looked at 1,500 patients, kidney disease patients that underwent IVF creation, and they were followed in terms of their maturation with 48 markers that are currently routinely assessed in clinical care, and none of these 48 markers associated with AVF maturation. So clearly, there's a need for new predictive biomarkers so that we can actually start individualizing dialysis care, increase patency, and successfully use an AVF. So the current understanding of AVF molecular biology is that is represented in this graph. This is a review, was just recently published, and I really like it because it shows the molecular signaling pathways that we currently understand. And I will use this graph throughout my next slides to show you what has been, what new insights have we gathered over the last 2 or 3 years. So first, I would like to talk a little bit about inflammation, and I want to talk about the different cells that are playing a role here in this IVF maturation, such as macrophages, T cells, certain T cell populations, and also the smooth muscle cells, wells, endothelial cells, how this is all related. For that, I'd like to show on the left how we currently understand that the inflammation is involved in successful AVF maturation and a longer patency. So you see that on the left, you have, for example, T cells and macrophages that help the vein to become more stronger and develop an AVF, which requires vascular wall thickening, but also an outward remodeling. If this happens in the early phase, which takes about a few weeks, then the AVF can be used for dialysis. However, there are problems sometimes related to this maturation, which causes an early failure of this AVF, which is quite common. So in this case, the vascular wall does not thicken and there's no outward remodeling. Again, in the later phase, you have again macrophages that help with creating a patent AVF that can be used frequently, can be chronically used to have actually patients on maintenance hemodialysis. This is in the later phase, takes a few months, but this can also be can also fail. So then you would have in this later phase a late failure because there may be hypoplasia or even inward remodeling. Now, there's a connection between the sirolimus or rapamycin pathway and this inflammation. So it's been known that rapamycin or sirolimus interacts with these inflammatory cells through the mammalian target of rapamycin or mTOR. When rapamycin or sirolimus binds to its receptor mTOR, the macrophage and T cell infiltration and proliferation can be manipulated. This has been shown in animal studies, and here you see that there may be new opportunities to improve clinical outcomes. As you can see in graph A, animals that had an AVF and treated with rapamycin had a longer patency or a more successful AVF use compared to control animals that were not treated with rapamycin. The AVF shown in B had a better smaller wall thickness compared to control animals, but the diameter of the AVF was the same. Just it illustrates that the animals treated with rapamycin had a more successful flow in their AVF. So this, of course, many studies that I'm going to introduce now are first done in vitro or in animals, and the huge effort needs to be spent on translating these bench experiments into bedside and treat patients actually. So these are now clinical trials that use the results obtained from animal studies with a rapamycin. What was developed is an rapamycin implant that was wrapped, shown on the right around the AVF anastomosis. So you see the vein and the artery, and they are connected through this AVF creation on anastomosis. And there are little collagen membranes that elute rapamycin. Initially, this was just shown in a patient population of 30, and 87% of those patients matured, and there were no systemic immunosuppression or no side effects, which prompted 10 years later a larger trial called Access 1 study. In this phase 3 randomized single-blind multicenter study, which recruited or enrolled a little bit over 240 patients, the study showed that patients over 65 years had a clear treatment effect, and their treatment effect resulted in a durable and significant maturation benefit. Again, there was no evidence of treatment failure and also no safety concerns. So, because that Access 1 study recruited anyone age 18 and older with an AVF, there's a new study planned called Access 2 study, where only patients older than 65 years are investigated. And I think this is a very interesting, promising way of interfering with the cellular and inflammation response by using these collagen membranes. Next, I would like to talk a little bit about another approach that was shown in animal studies preclinically to have really promising results. It's the elastase approach, where the hypothesis was that an accumulation of elastin could be removed by treating with elastase, which degrades elastin and would therefore result in an extracellular matrix deposition and breakdown to help an AVF mature. As I indicated, the early phase studies had really shown promising results, and there were hopes that clinical trials would confirm these results. So there was a first trial called Patency 1 trial. In this trial, 313 patients either received elastase, which is a recombinant human elastase that was applied locally. And then there were, of course, control patients. So two groups. And unfortunately, the primary patency didn't show any difference in the two groups. But what this study showed is that the secondary patency showed a slight significant improvement in the elastase treated group. That resulted in a patency 2 trial to just confirm, looking at the statistical significance between these two groups. Unfortunately, in this second trial, the initial patency 1 results could not be confirmed. The control group was performing better than the placebo group. So that was indicated as a reason for these patency 2 trial. Again, this was a disappointing result, and what was really important, though, is to highlight that the treatment, the local application of this elastase was well tolerated and safe, and that actually increases again hopes that something like this could eventually work in the future, just using a different target. Next, I would like to talk about this molecule called monocytrate chemotrectin protein 1. Again, this is involved in inflammation. Next, I would like to talk about a molecule called the monocyte chemotrectin protein 1. MCP1 is involved in inflammation, and increased levels of MCP1 predict restenosis after percutaneous transdominant angioplasty in AVF patients with stenosis. The specificity and sensitivity of this biomarker is fairly high, as shown in the graph on the left, and also the proportions without restenosis after a certain threshold is reached of MCP levels is shown in the second graph B. Next, I'd like to talk a little bit about this famous pathway TGF-beta. TGF-beta is really a jack of all trades, a master of everything. It's a master regulator of healing and is very tightly controlled. And if you systemically manipulate TGF-beta, it actually can result in excessive pathological repair. And you don't want to excessively have a pathological repair of your AVF. Early on, it was shown that there is a genotype polymorphism. There are actually a few genotypic changes that determine AVF patency. These genotypes result in patients that are having a higher production of TGF-beta in their plasma, and patients that have a lower TGF-beta concentration in their plasma. This is all based on their predisposed genotype. And here on the graph, you can see that patency is increased with patients that have this genotype, resulting in a lower amount of TGF-beta. So patients that have this genotype with a high concentration of TGF-beta in their blood had a lower patency, meaning that their fistula failed earlier. Now, this is genetics, and at this point, we can't really change the genetics of humans. So it is, though, a very interesting target because later on, just a few years ago, recently, a microRNA 133A was discovered, which is a negative regulator of TGF-beta. So you would not really target the concentration of TGF-beta systemically. You would actually target the expression of this microRNA that is then can influence downstream signaling molecules of TGF-beta. The way it works is shown in green is TGF-beta 1 that binds to its receptor, and this binding triggers the expression of microRNA 133A in the nucleus. Once this microRNA is expressed, it actually blocks the activity of the TGF-beta 1 downstream molecules, and so it regulates the effects of TGF-beta. So this is perhaps a promising new strategy to influence TGF beta 1 signaling and hopefully improve AVF fistula patency. Another promising target that was not reviewed in this initial molecular biology review that I showed earlier is the fractalkine pathway. This is something very recent that was investigated in humanized mice. Again, we have these animal studies that always inform whether it's worthwhile studying this in larger clinical trials. In this case, the ligand fractalkine binds to its receptor, and this binding causes a lot of macrophages to accumulate in the vascular wall. On the right, you see a histology where the lumen is pretty much closed when the fractalkine signaling is allowed, while when you block the binding of the ligand to the receptor, the lumen is free and there are no macrophages detectable in this lumen. So the patency in the animals treated with this blocker is improved compared to the animals that did not receive the blocker. This drug can be purchased, is available, and potentially a new promising target for improving AVF maturation and resulting in reduced stenosis, at least in these humanized mice. What we really need are clinical trials to follow up on this result. In the future, I would really like to highlight that there are many, many more ways to deliver drugs now based on nanoparticles. In this case, um, uh, liposomes are used to deliver prednisolone in locally to the injured, inflamed tissue. So when you create an AVF, the anastomosis is inflamed tissue and it actually becomes leaky, and that allows liposomes to permeate this membrane, and the concentration of whatever liposomes contain, in this case prednisolone, is higher at the site of inflammation. So when you imagine this AVF anastomosis, the prednisolone would be higher at this inflamed tissue location. And earlier results in animal studies really showed that prednisolone could be used, and the release could result in an increased AVF maturation. And there was a clinical trial called the LIPMIT study, where the prednisolone was supposed to improve IVF maturation. Unfortunately, this was terminated prematurely because of a very slow enrollment. What the initial results showed for the patients that were recruited, there was no significant difference between control and the liposome treated cases that contained prednisolone. But again, really promising is that the approach was safe and well tolerated by the patients, and it could become a very attractive tool for the future to deliver novel discovered regulators or drugs to inflamed tissues. So now I really like to shift a little bit gears by looking at new opportunities for using omics and non-pathway specific approaches. So far, I've talked about the mTOR pathway targeting inflammatory cells, the TGF-beta pathway, then elastase, MCP. These are all pathways that we know are nowadays are involved in AVF maturation. But how about actually targeting pathways that we don't even know are involved in AVF maturation? And that could be done with omics. And the reason for exploring these pathways in an unbiased approach is because of the most recent updated Kadoki guidelines, where it is stated that we are going away from a fistula first approach and the one size fits all to a right access for the right patient at the right time for the right reason. So that the care team can actually assist the patients with their decision for what vascular access they may choose for their kidney replacement therapy. And the reason why omics is such an interesting technological platform is it's a very unique opportunity, because you would not study these targets because they have not previously been considered. They are just identified by using this very broad omics approach. This could result in modifiable mediators that are causal and can be therapeutically targeted, but also in unbiased predictors could be identified that for considering all available vascular access options. So the care provider could guide with a score based on the omics discoveries that maybe a patient is more suited for let's say an AVF compared to an AV for an arteriovenous graft, something like that. And what I show down here is that these molecular signatures are actually very complex and barely understood. So when you go from a baseline to the actual successful AVF, you have a lot of different biomarkers that undergo this outward remodeling venous wall thickening process. And in fact, recent literature has shown that even before the creation surgery at baseline, patients have already pre-existing conditions to their vein that would advise against doing an AVF surgery. So there are clearly pre-existing factors that need to be considered, as well as during the process of AVF maturation, that process post-operatively could be assisted if we just know the molecular signatures during the life cycle of an AVF. If we collect liquid biopsies, for example, blood samples, we have access to so many different materials such as cells, DNA, RNA, proteins, molecules, small metabolites. And the technologies that would assess those are pretty much based on the material that you're interested in studying. So if you want to study genes or DNA, you would do a genomics approach, transcriptomics, proteins, proteomics, or metabolites, metabolomics. But even combining all of them in a systems biology approach is potentially very very interesting strategy to predict the AVF suitability of patients. And so because of these technologies, it actually opens the access to very different molecules that are available in the circulation. And you could create phenotype associated molecular signatures depending on where in the life cycle of an AVF the patient is. And it could guide clinical decision making about the vascular access that I have mentioned before. Now, we reviewed a lot of literature and found that there is rarely anything done in this field. Other fields really spearhead this approach of integrating omics with predictors of disease such as oncology, but in this field, we weren't able to find anything about proteomics or metabolomics being used. We did find interesting studies for genomics and transcriptomics approaches, and I want to highlight a very nice study that was just recently published by a group in Florida. This is the approach that they were using is called a two-stage surgery for creating an AVF. And the two-stage surgery pretty much consists of creating in the first stage an anastomosis. So you would connect an artery with a vein to create the AVF. And then you wait for a few days and then you go back inside and then transpose the AVF that you created to a different location that is more accessible for chronic hemodialysis. What this two-stage approach enables us to do is study the pre-access veins in the first stage surgery, and then in the second stage surgery, we can take a small sample of the AVF that will be used in chronic hemodialysis. And this two-stage approach has been shown to be safe and has shown similar outcomes as a one AVF creation surgery. So the study is described here in the middle of how many patients were recruited and enrolled. And first, I'd like to show you what happened when the veins, the pre-access veins, were compared to the AVF outcome. So here we see the fold change of failed versus matured AVF, meaning that if you have a higher fold change, that means it's upregulated, and these genes that are shown in red are upregulated, and they have a function. We know what these genes mean. The blue one is upregulated, but we have no idea about the function of that gene. And then there is a small one here in beige that builds a dimer with this one, S100A9, and so it was also considered in follow-up studies. Here, I'm just showing this differently, listing all the genes that were identified by RNA sequencing, which is a very new omics technology. And all of these 8 genes had to be confirmed by a secondary test called RT-PCR. And again, in RT-PCR, these 5 genes were found to be upregulated in failed AVFs compared to mature AVFs. And when this was also after the genes are expressed in RNA, then the RNA will be translated to proteins. So these genes were also investigated at a protein level. And what was shown is that 3 of these 5 confirmed genes were able to be investigated at the protein level. These 2 here could not be investigated because of sensitivity issues that were related to the assay used to evaluate protein. These 2 here were actually at the protein level significantly different between failed and matured protein. And it was very interesting because this protein, S100 calcium binding protein, is only found in endothelial cells and smooth muscle cells in the setting of inflammation. They're implicated, or this protein is implicated in the activation of NF-kappa B pathways and of the NADPH oxidase complex, which opens up a completely new direction of potentially new molecular targets. But this study clearly shows, because pre-access veins were used and compared with AVF outcome, that there is something that exists in the vein before actually an AVF is created, which results in a failure of the AVF, such as a genetic background or previous trauma to the vessels. Those could be reasons, and that is out of the surgeon's control because they come patient specific. And then I mentioned the second stage surgery, which enables to take a small piece of the AVF that was created. And with this, you could, we then compare the AVF transcriptome with the outcome of the AVF, whether the AVF matured or failed. And much to the surprise of the authors, there were not many differences between the outcome of the AVF and the actual AVF that was created. The only observation they did were in 2 genes. One stood for butyrylcholinesterase, and one was for immunoglobulin lambda variable 3.1. Those 2 genes were downregulated. The authors did not comment further on this immunoglobulin lambda variable, but they did find in published literature that there's a polymorphism for the butyrylcholinesterase gene, which resulted in a reduced enzymatic activity, and that was identified as a risk allele for coronary artery disease and in-stent restenosis. So this could be, again, a very new molecular target that has previously not been considered for manipulating and therefore have maybe a better AVF patency. Other of course, other approaches are currently in the pipeline, such as the hemodialysis fistula maturation study. This study recruited 600 patients that underwent AVF creation from 7 centers with a 4 years follow-up, a well-characterized cohort in terms of clinical, anatomical, biological, and process of care attributes. Other large, properly designed clinical trials will also need to be conducted where we can make conclusions about genome-wide association of IVF outcomes to identify key genetic risk factors. But again, these would require a huge patient population to really pinpoint genotype polymorphisms that will help to create more therapeutic options. A very interesting approach is something that I would call RNA imaging, where you do molecule and cellular barcoding, and you get a full picture of what RNA sequence or gene is expressed at what type of cell at the anastomosis, for example. So you see that macrophages and T cells or T cell subpopulations express certain kind of RNA that then could result in further improving AVF maturation. And last but not least, I'd like to mention our own MANVAS study here at the RRI. We teamed up with a big team spanning 3 continents and 4 countries to investigate metabolomics signatures in AVF patients that underwent IVF creation. And we collected, or the colleagues in Manchester in the UK collected blood samples before and after AVF creation, and then they sent the samples to the RRI, and we are currently processing these samples, did some metabolomics data analysis, and the data will then be sent and shared with Milind Nikam, who's in Singapore, and will conduct data analysis. In conclusion, I hope I was able to show that compared to the 2006 Gadoki guidelines, which kind of pushed for a fistula first approach, we are now trying to personalize the vascular access to the right access for the right patient at the right time and for the right reason. This is very different from what was proposed 10 years, more than a decade ago. And I hope with the presentation today, I could give a good overview about the current understanding and what are the most recent discoveries of actual pathways that are involved in AVF maturation. So we talked a little bit about mTOR, elastase, TGF-beta, and the monocyte chemotrectin protein 1. Again, I'd like to highlight here that it will require to carefully assess these molecular targets, because a systemic effect may result in unpredicted pathological opposite effects than what was proposed or hoped for. Then the novel omics approaches may reduce AVF failure rates, increasing patency and improve long-term outcomes. I hope that the one study I just talked about shows how new intervention targets and predictive biomarkers can potentially be identified. such as this unique inflammatory fingerprint that we found with the Martinez study in pre-access veins. But there's clearly a need for large clinical trials to confirm anything that has been studied in vitro animal preclinical trials or in a smaller patient population to confirm that the pathways identified actually result in the beneficial clinical outcomes. And there is always a fine balance between discovering something on the bench, translating it to the bedside, and then maybe go back to bench to finalize and interpret the new findings that were identified at bedside. So really the combination of molecular risk factors with clinical assessment is needed to reach that individual vascular access recommendation that is currently pursued with the KODAIKO guidelines. I would like to thank everyone for your attention, and I look forward to having questions. Thank you very much.